This note, I start my talk. A platelet is a very complex, comprehensive, and interactive molecule. There are hardly few cells or molecules in the body which are as active as platelet is, and that's why it's needed, because platelet has a very strong role of stopping bleeding across the body, and it involves itself into repair of daily wear and tear. So that normal physiological function of platelet at times becomes a hindrance as far as human life is concerned. Say, for example, somebody who has got acute atherothrombosis in any vascular tree, and that's where we need to adapt to measures, medicines, which can reduce the efficacy of platelet and create an atmosphere where further clot formation is arrested. So there are multiple antiplatelet agents which have been devised and which have been in market. I'll be very crisp and precise for all the physicians, I know that, so that they have a very strong carry-home message when they go home. So first, what about antiplatelet agents in primary prevention? So primary prevention is a state where a patient has no manifestation of disease, where patient has no history of events in the life as far as cardiovascular system is concerned. There have been multiple trials which have been done for primary prevention, most of them with aspirin. And if you look here, there are three groups of people whom we consider high risk as far as primary prevention is concerned. One is people who have got, based on clinical profiles, moderate to high risk, say for example, smoker, obesity, diabetes, hypertension, multiple risk factors. Second group is by diabetes itself. The people who have got diabetes, they are at high risk of cardiovascular event. And third is people who are senior, more than 65, 70 years of age. So in these three groups of people, these large three randomized trials which have been there in last 5 to 7 years, and this is something which is important. So when you use aspirin for primary prevention, in two groups of patients, there is no benefit as far as reduction in MI, stroke and death is concerned. One is people who are moderate to high risk based on clinical risk factors, and second is people who are elderly. So for these two group of people, high risk people and elderly people, for primary prevention, antiplatelet is almost out. But the central line, which is people with diabetes, if you look to the trial Ascend, in primary prevention, when you give aspirin to people, there was reduction in cardiovascular death, MI, stroke and TIA. So still diabetes is a segment, is a disease where for primary prevention, aspirin was useful. But what is most important to see is that people with, whether they are senior citizens, they have got high clinical risk or they are diabetic, the penalty to pay, the cost to pay for aspirin as a primary prevention is huge, and that is significant increase in major bleeding. We are not talking about epistaxis or subcutaneous bleed, we are talking about ICH or major GI bleed, which needs admission, attention, surgery or PCV infusion. So what we have to understand is when you use aspirin for primary prevention, you do get benefit to people with diabetes in terms of reduction in MI, stroke and death, but you do induce a huge risk of major bleeding. So how to conclude? So there have been multiple meta-analysis, and that's where they said it's basically a trade-off. When you give aspirin 75 milligram to 1,000 people for 1 year, you prevent 5 MI and stroke. At the same time, you give 4 to 5 major bleed. So it's 1-to-1, it's a trade-off. So that's where you have to be very careful in selecting patients if at all you want to give aspirin as a primary prevention. So these are 3 points which are very valid for primary prevention. Many people and physicians do ask me, Anish, in previous years when we started our practice, aspirin was greatly used as primary prevention, it was working, and we used to recommend. Now why a recommendation that as far as possible don't use aspirin for primary prevention? Because now we are treating our patients for blood pressure, for cholesterol and diabetes in a much better way. If you talk about 30 years, I have got senior physicians sitting here. The goal of blood pressure was maybe 150, 160. The goal of diabetes was not as perfect. And we were not using statin, or we are using statin to a minuscule dose. So when you treat a patient who has hypertension, diabetes, dyslipidemia to a target of less than 130/80, to a target of 7 HbA1c, and to a target of LDL 70, now once you have treated a patient by all these means, you have reduced risk to so much so level that adding aspirin will not give you further much benefit. So now, whenever you want to treat a patient with aspirin for primary prevention, first treat the blood pressure well, treat the diabetes well, get his LDL to 70 or maybe even 50 if possible easily, and then think of aspirin. That is number one. Second, you have to select people who are low bleeding risk. So whenever your brain puts an idea, can I write an aspirin for primary prevention? Then you have to see what is the bleeding risk. It has to be age less than 70 with low bleeding risk. What do I mean by low bleeding risk? A person who doesn't have past history of bleeding, a person who doesn't have manifested acid peptic disease, a person who doesn't have AV malformation, a person who doesn't have past history of stroke, a person who doesn't have anemia or thrombocytopenia, a person who doesn't have severe liver failure. So these are the people where bleeding risk is high. So first of all, when you, if at all you want to use aspirin, first is if you do not want to give your brain a big exercise, answer is no, don't use aspirin. But if you want to give a big exercise to your brain, rule out high bleeding risk points. Age has to be less than 70, and then a person should have a very high ischemic risk. Now you can define ischemic risk based on risk factor profiles, but there are two definite ways to define ischemic risk. One is CT coronary calcium score. The moment anybody who has got CT coronary calcium score of more than 100, they will get more benefit of aspirin as compared to risk. And second group of people, which is not as well studied, but there are indirect evidences that if lipoprotein A is more than 75 milligram, there is much high risk of thrombosis. So that's where you can. So in my practice, what I do is, first I treat them very aggressively for other risk factors. Then I give myself a question, is patient has got high bleeding risk? Answer is no, patient is a low bleeding risk. Say for example, somebody is 55, robustly built, no other issues. If CT calcium score is more than 100, give aspirin. Lipoprotein A more than 75, give aspirin. If none of these two things are there, I will hold from aspirin. Now, those people where you define to give aspirin as a primary prevention, if aspirin cannot be tolerated, clopidogrel can be a choice. So this was about primary prevention. Coming to a point of secondary prevention, we all know that till I was a student in MBBS, it was just one antiplatelet which we had available, and that was aspirin. But subsequently, we understand that a patient who has got acute coronary syndrome or a patient who undergoes PTCA has got high thrombotic risk. We all know that, and we wanted something that let us add something to aspirin so that a patient would have less thrombosis. So we started searching on various molecules, and one very famous molecule, that is P2Y12 receptor inhibitors, came into existence. Many of you are senior, you have witnessed the history of ticlopidine, and then subsequently came clopidogrel. Clopidogrel was the game changer as far as acute coronary syndrome and PCA is concerned. It tremendously reduced the risk of a patient, whether managed medically or through PCI. And then slowly we wanted better and better anti-ischemic molecules because clopidogrel has got certain issues. It has certain people who have got partial to complete resistance, and there was a serious concern about stent thrombosis with the stents which were available at that time. So we wanted better molecules, and then came prasugrel and ticagrelol. Now clopidogrel is a molecule which has got two-step metabolic conversion in liver, so that's why it is amenable to multiple drug-to-drug and food-drug interactions. Prasugrel has got only one-step conversion in the liver, so it is less amenable to drug interaction, and ticagrelor is a medicine by itself. It doesn't need any kind of conversion, so it has got the most reliable effect. So these multiple agents came, but as I talk to you, as you increase the strength of anti-ischemic therapy, as you want to fight thrombus more and more, you do tend to induce bleeding. So there was a penalty to pay, and when we started using all these agents, we had more bleeding. Again, there were people who had first generation stents. We were worried about thrombosis, so we kept on giving antiplatelet treatment for longer time. Unfortunately, in India, many people once put on DAPT are on DAPT for lifelong. That should not be the story. I'm very sure after today's talk, you will change your practice. So we kept on giving DAPT for a long time, and we induce more bleeding. Believe me, a very important point, when patient gets acute MI or stroke versus when patient gets a major bleed, either ICH or GI, they are equally devastating as far as life is concerned. They are equally devastating. Believe me, somebody whom you are giving DAPT after 1 year, and suppose he gets ICH, that's a devastating. Suppose he gets major GI bleed, you will have to stop both the antiplatelets for some time. That will again expose a patient to thrombosis. So it's very important to cut a strong balance between this. And nowadays we have got better stent. They are not having thrombosis. We have got better PCI techniques. We as interventionalists have improved our techniques. And so the risk of stent thrombosis is reduced. On the other side, we are now taking more and more riskier and riskier patients as far as anatomy and physiology is concerned. So we have patients where we put 5 stents. We have patients where we put 7 stents. We have patients where we put bifurcation stenting. We do left main stenting. And that's where again the risk of thrombosis is high. So how to make a balance and create a regimen for a given patient, a sweet spot where your ischemic and bleeding risk is balanced. See, now we have entered into an era of precision medicine. So there are guidelines. Yes, we know that we have to follow the guidelines, but what is more suitable for a given patient, we need to understand and adapt to that. So a patient who comes to you with acute coronary syndrome, a loading dose of aspirin followed by a maintenance dose of 75 milligram to 100 milligram. A maintenance dose of more than 100 milligram of aspirin is not needed, should not be written. Second antiplatelet is a must, but mind well, prasugrel is a medicine for interventionalist. A clinician should not initiate that. And you have to be careful, a person who has got past history of stroke or TIA, prasugrel is never to be used because it leads to more ICH. So somebody, say for example, comes to you with STEMI. What is the drug of choice? If that patient is undergoing primary PCI, which has to happen in all the centers where primary PCI is feasible, it has to be ticagrelor or prasugrel. While if you are in periphery where a patient has to undergo thrombolysis and you believe that patient cannot reach for primary PCI within 90 minutes of first medical contact to balloon time. So that's something important. I do get phone calls from an area which is 100 kilometers far that, doctor, I'm sending a patient for primary PCI. I tell them, please don't do that. You thrombolyze the patient, because once you have seen a patient of STEMI, if angioplasty cannot be completed in 90 minutes, you have to thrombolyze. So if you are thrombolizing a patient, second antiplatelet agent has to be clopidogrel, not tica or prasu. What about non-STEMI patient? Ticagrelor wins over everything. So when you see a patient of non-STEMI, elevated troponin, unstable angina, that's where whether you are managing patient medically or you are sending a patient for intervention, it has to be ticagrelor. So please, clopidogrel is out whenever you see a patient with elevated troponin. That's where the clopidogrel has got very poor results. Still many NSTEMI patients, even in Ahmedabad city, receive clopidogrel. No, they should receive only ticagrelor, 2 tablets as a loading and then 1 BD. Just a word about intravenous P2Y12 inhibitor, that is cangrelor. Again, that's a molecule to be used by interventionalists. Say, for example, I receive a patient with only aspirin who is STEMI patient. I'm going for PPCI and there is no time, so I can give injectable cangrelor. A very important use of cangrelor is, suppose a patient who has got recurrent vomiting. You have loaded a patient with P2Y12, but then patient is vomiting again and again, or patient is comatose, patient is in shock, patient is on morphine, where I believe absorption of P2Y12 will not be good. So that's where we interventionalists do use cangrelor in our practice. What about GP2B3 inhibitors? This was a molecule which was well used by many clinicians previously, that when a patient of NSTEMI, they used to start this and then used to send the patient for PCI. Now, again, GP2B3 inhibitor, that is tirofiban or eptifibatide, is not to be used by clinician. It is to be used only by interventionalist on table when we see huge thrombus burden. So in your practice, when you see a STEMI patient, aspirin plus ticagrelor, if patient is to be thrombolyzed, clopidogrel. When you see NSTEMI patient, aspirin for ticagrelor. That's extremely clear. Nothing else is to be used. What about duration of DAPT? That's where in last 10 years, multiple robust trials have come. If you look as a default strategy, if you do stenting in a patient who has got stable ischemic heart disease or chronic coronary syndrome, it has to be aspirin plus clopidogrel or ticagrelor. That's very clear for 6 months. And after 6 months, if a patient had stable ischemic heart disease for which stenting was there, you can switch over to single antiplatelet. While in a patient who has ACS, we give dual antiplatelet treatment for up to 12 months or more as a default strategy, and that's where tica or prasu rules over clopidogrel. So this is a default strategy to be done in almost majority of the patient. But then you cannot have this strategy in every patient. Say for example, there is a patient who has got high bleeding risk. Now exposing that patient to aspirin plus ticagrelor for 1 year may not be good. So what is most important is, as far as length of DAPT is concerned, you have to take into consideration multiple clinical and procedural parameters and define what is called as what is ischemia versus bleeding risk. There are certain features which increase is ischemic. Say for example, somebody who has got diabetes, high ischemic risk. Somebody who has got multiple acute coronary syndrome. Somebody who has got multiple stents. Somebody who has got stent at bifurcation. Somebody who has got stent at left main. So these are high ischemic risk. That's where a patient has more chance of having future event in terms of MI and stroke. While on the other side, there are patients who have got high bleeding risk. Say for example, patients who are aged, patients who are frail, patient with low muscle mass, patient who has CKD, patient with diabetes. So diabetes presents a very serious clinical dilemma. On one side, there is increased ischemic risk. On other side, there is increased bleeding risk. So that's where how to curtail, how to continue DAPT. So when you see a patient, you have to put a patient into bleeding risk versus ischemic risk. On x-axis, it is ischemic risk. On y-axis, it is bleeding risk. And this you have to do at the time of SES, and then every 3 months when you call a patient for follow-up. Say, for example, let me give you an example. What is high ischemic and low bleeding risk? This is the area, high ischemic, low bleeding. A gentleman who is robustly built, 76 kg of weight, 60 is the years of age, diabetes, acute coronary syndrome, 5 drug-eluting stents, multiple bifurcation stenting. Now, this gentleman is well built, has no anemia, no thrombocytopenia, no history of bleeding. He is robust and he has got multiple stents. So his risk of bleeding is less, while his risk of having recurrence of ischemia is more. So that's where you tend to give DAPT for maybe 2 years, 2.5 years, 3 years. That's where your concern of bleeding is less. On the other side, let me give an example of somebody who has got low ischemic risk but high bleeding risk. Who is that? A female, 74 years, very low body weight, low platelet count, anemia, presented in chronic coronary syndrome, and just I put 1 stent. Now this lady, look at, she is very frail and fragile, and she has only 1 stent, so her ischemic risk is less, but her bleeding risk is very high. That's where I might stop DAPT at 1 month, maybe 2 months, or maybe 3 months. That's it. More than 3 months of DAPT is not needed for a lady because you are going to induce bleeding. So even if a patient had acute coronary syndrome, in such patients we curtail the second antiplatelet at the end of 2 to 3 months. But the strongest challenge comes from people who are high ischemic, high bleeding risk. Let me give you an example. Female, 70 years, already high bleeding risk, low body weight, diabetes, high ischemic and bleeding risk, CKD, high ischemic and bleeding risk, anemia, high bleeding risk, SES, high ischemic risk, low EF, high ischemic risk, 3 drug-eluting stent. What to do? So this is one very serious area, and that's where I will discuss in next 5 minutes what are the treatments. So number 1, people who have got low bleeding risk, well-built, young people, and high ischemic risk, that's where you can go for prolonged DAPT for 2 to 3 years. But mind well, when you give prolonged DAPT, it reduces risk of ischemia, increases risk of bleeding. So you have to be careful to select patients who have low bleeding risk, but you do not change the mortality. So sometimes people tussle a lot. I will give DAPT for 1 year. Somebody says, no, I'm going to give it for 2 years. Believe me, you are not going to change the mortality. You are just going to change the ischemia versus bleeding. So what is more important for you today is to understand what are the high bleeding risk features. And in every patient, you have to look for all these features. Age more than 75, severe kidney or liver disease, active cancer, anemia, thrombocytopenia, past history of stroke, bleeding diathesis, patient already on warfarin or NOAC, patients who need steroid or NSAIDs for some serious purpose. There are people who are on steroids, say for example, autoimmune diseases, or if a surgery is planned in near future. So these are the people who got high bleeding risk, and that's where you have to curtail the treatment. Now, a default strategy in SES-PCI is to give DAPT for 1 year at least. Now, what can be strategy by which you can reduce bleeding risk? Number 1, at the end of 3 months, you continue aspirin and stop the P2Y12 inhibitor. This is a well-established strategy which you can adopt. The another strategy is reverse. You can stop aspirin and continue P2Y12. That strategy is becoming more famous across the world because this strategy brings a very strong balance between ischemia and bleeding. People could found that if you continue aspirin, there is more GI bleeding risk, while in this strategy, the bleeding risk is also less and it is more effective. So in your patients who have got high bleeding risk, think of this strategy. And then there are 2 strategies. So these 2 strategies which I discussed are called as DAPT for short time, followed by single antiplatelet. While there are 2 strategies in which you continue DAPT for 1 year, but after 3 months, you reduce the intensity of second agent. What do we do is, you give DAPT for 3 months, and then you had given Tika and Prasu. Now, after 3 months, you stop Tika and Prasu. They are more potent, more bleeding risk drug, and come down to aspirin and clopidogrel. This is a very important strategy. Mind well, I personally in my life continue Tika or Prasu for 1 year in hardly 10% of patients whom I treat. I do not continue them for more than 3 months in my majority of the patient. Second strategy is, again up to 3 months, you give Tika, Prasu and aspirin, and after 3 months, you half the dose of them. Tika instead of 90 BD, go to 60 BD, and Prasu instead of 10, go to 5. So these are 4 strategies. Stop P2Y12 and continue aspirin. I do not adapt to this strategy. Stop aspirin, continue P2Y12. That's a reasonably good strategy. Or you come down to clopidogrel or half dose of Tika. So these are multiple strategies to be adopted in a patient who has got high bleeding risk. I won't go into the details much. So just taking you to sort of conclusion, a default strategy in a patient who has got acute coronary syndrome and PCI, it's 12 or more months of DAPT. That's a default strategy, mind well. And there are many patients who would fall into this. Suppose I get angioplasty with 3 stents, I will fall into this because I have got very low bleeding risk. I would like to continue it for 2 to 3 years so that my ischemic risk is reduced. Then there are multiple strategies for people who have got high bleeding risk. Out of that, the best and most tested is continue aspirin for 1 to 3 months, then only continue Tika. This strategy has become very robust. So 1, 2 or 3 months aspirin plus Tika, and then stop aspirin and continue Tika. That's where you are very safe. That's where there is very minimum risk of MI and stroke. At the same time, risk of bleeding is less. A very important point which I discuss is the last column. That's where you give aspirin Tika for up to 3 months and then go to clopidogrel. So this is also an adaptable. So in my practice, I adapt this strategy for high bleeding risk, or I adapt this strategy for high bleeding risk. A very important point for people who are already on oral anticoagulation. See, your patients of atrial fibrillation who will be on either NOAC or warfarin. Better is always NOAC. There are patients who got DVT and PE who may be on NOAC or warfarin. There are patients who got mechanical prosthetic valve who will be on warfarin. So what is most important is when you have to give triple therapy, that is aspirin, P2Y12 and oral anticoagulation, aspirin has to be 75 milligram. It has to be clopidogrel, no praso, no Tika, 75 milligram, and try to take NOAC rather than warfarin. Yes, warfarin is must when patient has got mechanical prosthetic valve. You cannot have NOAC there. For DVT-PE, for AF, it has to be NOAC. So triple therapy has to be there only for 3 days to 1 month. Aspirin, clopi and NOAC, only 3 days to 1 month. Then after that, stop aspirin, be on clopidogrel and NOAC, and maybe after 6 to 12 months, only NOAC. A patient of ischemic heart disease, a patient of acute coronary syndrome, if is on NOAC for atrial fibrillation, doesn't need aspirin or clopidogrel after 1 year. So this is very important, extremely important, because many patients, many clinicians do call me, Anis, we have to give. No, there is no need. It's very well proven database. So ladies and gentlemen, to conclude my talk, it's very, very important to judge ischemic versus bleeding risk. A physician has to do this. You cannot get away without doing this. Every 3 months when patient comes to you, you have to. And I have discussed what are the points on which you can conclude that bleeding risk is high. It's very simple. There is nothing much needed for that. This you do on the daily practice. So a default strategy is DAPT for 1 year or 3 years, followed by aspirin or clopidogrel alone. There is another strategy which has been discussed. People who have got very high ischemic risk, polyvascular disease, multiple SES, past history of stroke, peripheral vascular disease, that's where you have to give aspirin plus rivaroxaban. But again, this is the highest bleeding risk strategy. So you have to be very careful to select low bleeding risk, high ischemic risk. And a strategy which I discussed today and which becomes more and more relevant, there are many patients who have got high bleeding risk. So that's where you have to stop DAPT at 1, 2 or 3 months and then continue single antiplatelet for rest of the life. Thank you very much for your kind attention. I'll be open to questions, comments, and suggestions.